My name's Kaytlyn, and I'm here today with two other classmates, Kaylyn and Sarah, and we are here with the wonderful Chandler Smith, who is a physician assistant in the Burn ICU at UF Health Shands Hospital. And we're going to be talking about controlled substances in the ICU, balancing comfort, safety, and regulation. We're going to be focusing on opioids, benzos, sedation practices, withdrawal management, and prescribed controls in the acute critical care setting.
Okay.
Question number one, we're going to talk about kind of the landscape of controlled substances in the ICU. Chandler, what are the most commonly used controlled substances in your ICU setting?
In our ICU setting, we typically use oxycodone for post-surgical pain management, as well as fentanyl and Dilaudid for breakthrough pain. We also utilize infusions of fentanyl and Dilaudid for our intubated patients, and we use propofol. I think gabapentin's now considered a controlled substance in some places. Versed, we use a decent amount of Versed, and those are the most common ones that we use.
Okay. How do you decide what to use for sedation versus pain control in critically ill patients?
So sedation and analgesia are two very separate things that go hand in hand. So the first thing ultimately that decides what we use is do they have an airway? So are they intubated or are they not? If they're not intubated, we have to be more careful with our pain and sedation. So we, for specifically our burn debridements or wound care, we'll use PO Versed, which actually tends to work very well for our patients. We also will utilize a ketamine infusion and fentanyl pushes. Those are all for our patients who are awake without a breathing tube, who are at a higher risk of respiratory suppression. For our intubated patients, it's ultimately up to their hemodynamics. So unfortunately, propofol, especially in a new burn and very sick patients, propofol and Precedex will drop blood pressures very quickly. So if that's the case, we'll use a Versed infusion for sedation. For analgesia, it's kind of hit or miss. I go for fentanyl infusion first. If the fentanyl seems to not be working, I might try a dose of Dilaudid. If that seems to work, I can switch to a Dilaudid infusion should they be intubated. Otherwise, we use ketamine for analgesia and sedation. It works pretty well for intubated patients. There are cases where you have to use a benzo adjunct if they go into what's called like a dissociative ketamine hole. But I'd say the primary things are hemodynamics and whether they have a protected airway.
So how has your approach to using opioids and benzos changed over time? Like, for example, have you trended away from deep sedation?
Yes. With my time in the ICU, I have encountered many cases where the patient has been deeply sedated for many days and it becomes extremely difficult to wean them from their sedation and their analgesia. It causes both patient, family, nursing, and provider stress because the patient often can be very delirious and can be combative, or they can be hypoactive, causing us to look for something worse. So what I like to do is I like to take into account why the patient, if the patient's intubated, why are they intubated? Are they intubated for airway protection, or are they intubated for a big burn, specifically in our unit? If they're intubated for a big burn, likely their chances of being extubated in a timely manner are lower because their metabolic needs are a lot higher and they can't manage those without a breathing tube and a ventilator. So for those patients, I'll keep them a little bit more comfortable. I'll have their analgesia set a little bit higher as well because they do have a big burn that's relatively uncomfortable. For our ENT patients, which are usually intubated for airway protection, I'll keep them a little bit lighter on their sedation so that they can participate in their care. So physical therapy, occupational therapy, and just to reduce their chances of in-hospital delirium. So with those patients, we might use a Precedex infusion as long as their blood pressure will tolerate. But since I've started, I feel a lot more comfortable with sedating people and making sure that and keeping an adequate pain control. That's come with just experience of how to correct the course if I've overdone it or underdone it. But that's just kind of how that's changed.
Awesome. And then a follow-up question to that. Have you had to change any of your protocols or like medication choices due to drug shortages or any policy changes in your setting?
Yes. So when I first started in the burn and ENT ICU, we had no fentanyl. We couldn't use the fentanyl infusion. We could use pushes, but no infusions. So when I first started, we relied heavily on ketamine and Dilaudid for analgesia for intubated patients. And then later into my career, we had a ketamine shortage, which was honestly one of the worst ones that we've had. Ketamine is an excellent drug when used correctly. So for that, we had to kind of stray away from ketamine, and that did impact our wound care ability to treat pain during wound care a lot for our non-intubated patients. And then briefly we had a Versed shortage, and so we had to rely heavily on propofol and Precedex, which unfortunately with our hemodynamically unstable patients, we had to then add adjuncts of pressors to keep their blood pressures appropriate while we kept them sedated while we were out of Versed.
Another follow-up question. How do ventilator days or weaning strategies play into your medication decisions?
That's a really good question. It plays super heavily. So like I said, with our big burns, whom we know that their metabolic demands are going to outrun their body's ability to meet their hypercapnia on their own. We will keep them on a little bit deeper of a sedation level. So we'll keep them on, if they're on Versed, we might keep them on the Versed for a little bit longer. However, when we feel that the patient is ready to be extubated, whether it's because their metabolic demands are lower or they're an ENT patient and their airway edema has gone down for whatever reason, when we start to lean towards extubation, we will definitely trial Precedex and ketamine infusions, as both of those are less likely to decrease your respiratory suppression. So less likely to affect our ventilator, their ability to spontaneously ventilate in preparation for extubation. Now, should the patient fail those two measures, we like to use propofol. Propofol, our big motto for that is quick on, quick off. So it's excreted out of the body pretty quickly. So we can turn it off, give the patient about 30 minutes, and then safely extubate them without the respiratory suppressive effects of propofol.
So segueing into our second part of the segment, it's going to be more focusing on safety tolerance and withdrawal. So how do you manage patients who are on high doses of controlled substances for extended ICU stays?
So it really kind of depends on the patient. So the ENT patient who comes in on high doses of opioids for cancer pain will most of the time will have a high level of surgical pain. So we will, for a time, pretty post-operatively, we will have to increase their opioid dosages to meet their home needs as well as their new surgical pain needs. But as their stay moves on, we like to try to wean them closer to their home dose. For our burn patients, we often add methadone as an adjunct as a long-acting opioid. So the methadone will help us a lot of the times decrease our continuous analgesia infusions and decrease their PRN and oxy needs. And all of the burn patients are weaned off of methadone prior to discharge. So we use methadone strictly in hospital. And then there are the patients who, no matter how hard we try to treat without narcotics, they do require high levels of narcotics. And in those cases, we end up consulting pain management if we feel like we are out of our scope, out of our expertise. And we will also consult palliative too if it seems to be more related to cancer pain.
Okay, so what signs of tolerance or withdrawal do you look for, and how do you intervene?
So for tolerance, I look at the dosages. Like I look in the MAR, I look at how many doses of their narcotics they've used, and has that amount of doses, has that increased, stayed the same, or gotten better? So for the patients who are becoming more tolerant to the opioids, I often see that the number of narcotic doses that they take is a little bit higher, and often they'll need some breakthrough pain medicine and pain management. And then for withdrawal, we had a patient recently whom we believed might have been taking more of their home narcotic than was prescribed. And so we thought we were meeting her home needs. However, we were under meeting those basically because she was taking them more than prescribed. And so she had this unresolved tachycardia that had no other underlying cause. She was very anxious. She had lots of nausea. She was a little bit, she luckily wasn't any kind of agitated, but she's definitely anxious. And as soon as we treated her pain, we noticed that her tachycardia improved, her anxiety improved, all of those things when we treated her pain with narcotics as opposed to a non-narcotic alternative. So we look for vital signs. I look for patient behavior. A patient who's withdrawing might become a little bit more agitated. And yeah, that's kind of what we look for tolerance.
And I know, Chandler, that the burn patient population is very different than a lot of other patient populations as far as like pain control, and the burn debridements are really big things. So do you guys have specific protocols set in place for like tapering or transitioning your patients off some of the medications that you utilize during their more critical days?
Yes, so I would say methadone's our number one adjunct that we use to try to wean them off of the narcotics. However, during rounds, we will constantly talk about where their non-narcotic pain management options. Where are those? So are they maxed out on their gabapentin? Do they need to be switched over to Lyrica? Are they able to take Tylenol and ibuprofen? Is the surgical team okay with the patient taking ibuprofen? And then also, once they start to become more closed, which is when the patient has undergone autografting and their surgeries are next to done or almost done, we will start weaning. We'll start with the narcotics first. The first one we'll wean is methadone if they're on it. If they're not on methadone, we will start to wean their as-needed oxycodone dosages, and sometimes that does require up-titration of their non-narcotic adjuncts. But most of the time, and then with their debridements, as they get closer to discharge, we start to do their debridements we wean them over time, but we start to wean them to a point to where they do not need any narcotics for wound care. They might need PRN oxy when they go home, but the as needed, the PRN fentanyl pushes will go away certainly before they leave.
Awesome.
Yeah.
So you already touched on pain management services a little bit, but how do you involve interprofessional team members like pharmacy or psychology in complex cases?
Oh, the pharmacists are our best friends. Anytime I'm like, I need, a morphine equivalent dose of something, or I need some alternative ideas because I'm not able to manage a patient's pain without narcotics, or really any questions I have about pain management, to where like at other options, I'm able to talk to our in-unit pharmacist, who's excellent. We do, like I said, we have had cases where the patient has just needed a significant amount of pain medicine that is above what we usually give. In those cases, we have, and it's pretty rare that we end up having to use it, but we call acute pain services. We also will call acute pain if the patient comes in on a hefty dose of narcotics prior to their surgery or their injury, because the likelihood of us being able to manage that pain can be a little bit difficult. For example, we had a patient who had an implanted baclofen and fentanyl pump in his back, and so we definitely needed the assistance of the pain management and anesthesia services for that. And then when we come to the conclusion that maybe the patients, if it's an ENT patient, maybe if their flap has failed or their cancer's recurring, that their pain would be better managed by the palliative care service. So in that case, we'll call palliative and see if they have any suggestions for their pain management. But for the most part, post-surgical pain, we are able to manage on our own. I'd say almost 100% of the time. There are the cases, though, where it's just not possible, and we use our resources.
So moving into the next part, burn definitely brings up this is like real world challenges and ethics as being a burn nurse previously. I know there's a lot of those problems that arise in that ICU. So what are some of the toughest clinical or ethical decisions you faced regarding controlled substance use in the ICU?
I think the hardest is when, based off of my experience and clinical knowledge, when a patient is asking for and requesting more narcotics or more controlled substances than they actually need. A lot of the times, they always say, pain's not a vital sign, pain is perceived. But there are some associated vital sign changes in patient behaviors that also change too with pain. So keeping in mind the patient's perceived pain as well as their safety can be very, very difficult, especially if they're displaying seeking behavior. The other ethically challenging thing is when family members start to request narcotics or benzos or any controlled substance for their family member, but the family member clearly is denying them or clearly does not seem to require them. That's a hard line. Ultimately, at the end of the day, I'm supposed to be treating the patient, not the family, but the family does come into play when you are treating any patient. So it's definitely difficult, and then it is very, very challenging. I think I mentioned it before when you have the extremely delirious patient who now has to come off of the medications that are essentially making them delirious, and the delirium gets worse. And like I mentioned, it causes nurse stress, it causes provider and patient stress, just because the patient becomes more agitated and more difficult to manage. But at the end of the day, taking away some of these sedating medications is going to be what's going to help the patient end their delirium and kind of finally come out of it safely.
Gotcha.
And then kind of following up on that, how do you balance patient comfort, especially like end of life care when, you guys have decided that this patient, and the family has decided not to continue with anything. How do you balance that with like regulatory oversight and documentation of your controlled substances?
Yeah, that one's, I feel honestly the most comfortable managing the pain of the patient in an end of life care situation. At the end of the day, I want the patient to pass peacefully and and I would love to have them pass without pain. It's not always possible, but keeping up with an appropriate dosage of pain medicine for them, whether that be a continuous infusion or hourly pushes of morphine or Dilaudid or as needed oxycodone, whatever the patient needs and whatever the patient perceives as their pain, they will be treated appropriately. You do have to be very careful because you don't want to give a lethal dose of any kind of pain medicine to quicken the process of withdrawal of care, but you do want to keep the patient comfortable. So those, within reason, basically, you kind of take into account the patient's tolerance of the pain meds. So if it's a 94-year-old grandmother who's, deciding to do comfort care and she responds well to a small dose of 25 mics of fentanyl, then we'll give her the 25 mics of fentanyl doses as she needs. But if it's another patient who might be a little bit younger, who's a little bit less tolerant, they might need a little bit more fentanyl, or they might need Dilaudid, or they might even need a continuous infusion. So it's ultimately titrating to what the patient needs at the end of the day for those patients.
Awesome.
So for our last segment, any pearls or practice tips and takeaways, what advice would you give to new APRNs or even ICU nurses regarding controlled substance use?
I think my biggest piece of advice, and both Kaylyn and Kaytlyn have heard me say it, is look at the patient. The patient's going to tell you everything you need to know 90% of the time. So if you walk into the patient's room, they're diaphoretic, their heart rate is significantly higher than their baseline, they look uncomfortable, they're getting wound care actively, don't be afraid to give the opioid. or the controlled substance or the benzo or whatever the patient may need at the time. And my other biggest pearl is sometimes it's really scary to give narcotics because, and any kind of controlled substance, really, anything that can suppress the respiratory drive, which a lot of those controlled substances do. Because it can be, if the patient doesn't have an airway, you run the risk of them, their respiratory drive being so suppressed that they could respiratory to cardiac arrest, that kind of thing. But that's the scary part. But knowing how to reverse things is the other most important part of giving a narcotic or giving a benzo, right? So if you know how to reverse the controlled substance, it's less stressful to give, and I have found that I have become a little better at treating the patient's pain and anxiety because I know what I can do if something goes wrong. So like I said, 80-year-old grandma, might not be able to tolerate 100 mics of fentanyl, but 6'10" basketball player who's 25 is not going to be able to tolerate, they'll be much less tolerant to a smaller dose of a narcotic. So knowing a backup plan, knowing what you're doing and how you can fix it if something were to go wrong makes treating the pain and anxiety much easier and less scary. But like I said, the most important thing to do is look at the patient.
Yeah,
solid advice.
Yeah, thank you.
Yeah. You guys have any other questions?
Go ahead. Okay, our last question. Are there any emergent practices or evidence that you're excited about or that you've heard about recently as far as maybe daily sedation vacations or nurse-driven protocols in your patient settings?
I think just educating our nurses becoming more comfortable with doing the sedation vacations and speaking up for their patients, that's really, for me, very exciting because our unit has a lot of very, very new nurses, so some of these things for like daily sedation holidays or cutting the sedation or narcotic in half can be a little bit daunting for the new nurses. So as they're getting more experience, that's really exciting. I also recently, and I don't know where I read this, but I saw that they were going to start using some nebulized ketamine, in the ED. So I thought that was actually really cool.
Yeah.
Because if we could use that, I think about it all the time for our burn patients undergoing debridements. The dissociative effects of ketamine are excellent, and a lot of them have drastically improved experiences with the intravenous ketamine. So if we could nebulize the ketamine, that would be really cool. I don't know how accurate it is, but I think that'd be really awesome.
That'd be great. Military-wise, TCCC is our trauma. Ketamine is number one drug.
Yeah.
You use it for everything. And so it's really a great drug option.
Yes. I think ketamine I think it's a wonder drug. I know it can cause patients some distress if it's not administered correctly. Mm-hmm. But when administered correctly and given appropriately, it's an absolutely excellent drug. And something that I wish we could go back to is at Shands, at least, APPs are no longer allowed to push ketamine without the presence of an attending, which makes my night shifts difficult. If I deem that the patient would benefit from a dose of just push-dose ketamine for their initial burn wound debridement, which is usually very painful, I am restricted by that. So maybe, hopefully, some advocacy from our APP council would be excellent into getting back to that.
Well, Chandler, that was our last question, and thank you so much for your time today. This has been wonderful, and I'm definitely taking away a lot of information, so I really appreciate your time and all of your wisdom and knowledge that you've passed on to us today.
Yes, you're very welcome.
Thank you so much.
Thank you.
You're welcome. Okay.